Good morning, everyone, and welcome to the Tortoise Global Health Summit. My name is James Harding. I'm the editor and co-founder of Tortoise. And this pandemic year has changed the way in which we approach journalism in many ways. One of them is to try and think about the forces shaping the world we see. We are, I think many of us, overwhelmed by the daily news digests, not least around infection rates and, as we saw overnight, death rates from COVID-19. And it's hard to feel anything other than helpless in the face of the information we get. And part of what we've tried to do with these summits is take some time out of the daily run of the news to stop and try and understand the issues we're facing and how best we might address them. They're deliberately constructive and they're deliberately looking at the bigger picture. And there can be, if you like, no bigger picture than what's happening in and around health and our healthcare services. As is always the case with a Tortoise Thinking, it's intended to be like an open editorial conference, an open news meeting. We're incredibly fortunate that we've got some people who really know what they're talking about. Sally Warren, who oversees policy at the King's Fund and is deep in understanding the choices that healthcare systems and governments make. She's worked for years in different parts of Department of Health and in fact all across government, Sally. So thank you for joining us. And Dr. Jonathan Pearson Stoddard, Johnny is here too, has written a book, Whose Health Is It Anyway, which I hope is not entirely cribbed from Whose Line Is It Anyway. It's more than just an ad lib on the state of our healthcare system, but is an inducement and encouragement to us to think about health and the way in which it operates in the UK. But for as much as they've got expertise, in this particular subject, we all do. We all have our own experiences, and I hope that everyone will feel willing and eager to weigh in. The nature of what we're going to do through the course of the day is hear from people, take down what we learn in the chat and try and come to a better understanding. And it's focused on healthcare and health systems, trying to have a better understanding of how we approach health in the UK, but also globally. We're extremely grateful to Scottish Widows, who've been the sponsor for this and helped us to get this summit up and running. And I hope that the outcome of it, like as with our Global Education Summit, is we really think from the ground up. We begin to think about different ways of addressing one of the biggest issues facing society. So with that, I'm going to turn to Sally, because Sally, as I was saying just before we started, and forgive me, I'm going to sort of give a plug for the King's Fund. If you want to understand the choices that you make as a country, it's no bad thing to spend half an hour on the King's Fund website. You really understand the choices we can make as a society, and the truth is that we've had a go at making pretty much every single one of them along the way. Can you just give us a sense of, this session is intended to be about the NHS and whether we need to change the funding model. What are the funding models that are available, and is that the right question in the light of what we've learned in this pandemic year?
Good morning, James, and morning, everybody. It's great to be with you. It's quite a big question to start off at 9 o'clock, isn't it? I'll just briefly summarise the key different ways that globally countries fund their healthcare service. It's really important to say that most countries actually have a combination of the funding models I'm going to talk about. So they're all slightly unique combinations of this way of thinking about it. But the first way, obviously the one we're most familiar with across the UK, is general taxation. That is basically your risk pooling your need for healthcare across the entire population. Countries that use this model are obviously us, Australia, Canada, New Zealand, the Nordic countries. They do all have a slightly different model about where they draw their taxation from. Sometimes it's national taxes, sometimes it's more local, but the general model is it's funded through general taxation. The next potential model is the private health insurance model. And this is where the public is either required to take out private health insurance or is strongly encouraged to. Obviously, that's the dominant market in the US in terms of healthcare provision. In Switzerland, for example, it's mandatory for individuals to take out private health insurance. What we've tended to find in terms of what experiments have happened and sort of failed in a number of countries, the UK and several other countries have encouraged people to take out private healthcare insurance by giving tax relief breaks. And actually in the UK, those tax relief has been withdrawn because it was considered to be an unsuccessful policy and poor value for money. And there's been similar experience in France and other places. So private health insurance works in some places. And then the next model is social health insurance. This is where the employer and the employee both pay based on the Bismarck German reforms. To give people a sense, in Germany, it's around 15% of your salary. This is used in Germany and in France and in Japan. Really important to say, though, this does require a combination of other funding models as well. So quite often it requires a form of safety net for people who aren't employed. So you have a general taxation funded safety net. In Germany, for example, there's co-payments as well as the payment into the social insurance scheme. The final way you might be able to pay for care is kind of paying at the point of need, so charging for care. This is something we do have in the UK, so we charge for dentistry and optical care, and we charge for prescriptions. So it is worth saying 90% of all prescriptions in the UK are free and not charged for, so it's a small proportion of prescriptions that are charged. Quite often people think charging is a really good way to manage demand and kind of stop inappropriate use of healthcare services, but actually there have been a number of studies, most recently by Rand, that also is clear that charging can deter appropriate use of healthcare as well, in particular for low income clients and those with the highest healthcare needs. So actually charging at the point of use could increase inequalities and make people's health worse.
And Sally, when you look across, that's really helpful to get that sense of the sort of general taxation model, the private health model, the social health model. When you look across all of them, they've all got their pros and cons. Is that the question? Is the funding system for healthcare instrumental in improving health outcomes?
So it contributes, but it's not actually the biggest contributor. So if we think about what drives our own health and well-being, broadly 20% of what causes our health is our healthcare services. There's a slightly smaller proportion, which is our genetics, but the vast majority of what determines our overall health is what we call wider determinants of health. That's a whole set of things around the environment we live in, the education we had, the quality of job we have, the quality of housing, access to green spaces, good air quality. All of those things really drive how healthy you can be as a nation. The NHS is then sort of really there to help you when you're sick and you're unwell, rather than there to really be using all of those levers to really think about health. So when you think about the kind of question about is the right question a funding model about healthcare services, actually the OECD say there's no particular model for funding healthcare which on a systematic basis delivers better outcomes and a more efficient healthcare services. The NHS actually comes out pretty well on a lot of international comparisons. So the Commonwealth Fund looks across 11 countries and we actually come out number one overall, but really importantly, we come out 10 out of 11 on health outcomes. So that can show how you can have a really effective healthcare service, but actually not very good health outcomes, which is what's determining our quality of life and our length of life. So I think there's a really important question about health in the round rather than just healthcare services.
And Sally, when you talk about those wider determinants, can you help us understand a little more deeply exactly how those play out? You said education, housing, air quality. I don't know how blurred the correlation is between those things and health outcomes, or whether or not people can, with some precision, define for you the extent to which they contribute to health.
Yeah, so you can define, and different kind of frameworks and studies have looked slightly differently at the proportion of your health that is determined by those wider determinants, but there's general agreement across all of those frameworks that it is the majority impact. And if you think about even looking at the kind of current COVID crisis, you can see absolutely how some of those wider determinants are impacting on how people are being able to cope and through the pandemic. So housing. Are you living in high density housing, which might mean you're more exposed because you've got more people in your household? Your job, I'm really lucky. I've got a job that means I can work from home very easily. I can work very flexible hours. A lot of other people don't have that flexibility in work. So they've been exposed to greater risk because they've been needing to travel to work. They may not have the same financial security to be able to isolate when they need to, etc. So you can see that even through this last 12 months, people have different levels of resilience because of the situation they live in, the environment and the context of which they live their life, that means they have better or worse opportunity to have good health. So it's those kind of questions. And obviously the key challenge is that quite a lot of those things are not, you just kind of press the button and go, I want better air quality, and you immediately get that improvement in health outcomes. Quite often they can take quite a long time to see the benefits in people's health. But it's really important, if we want to change the pattern of demand, if we want to change the pattern of health in this country, that we need to be thinking about that medium and long term improvements in our health, which requires us to have a system that incentivizes Treasury and other parts of government to be thinking about the long term and not just thinking about how to pay for the demand for NHS today and tomorrow.
And do you have a ranking of those wider determinants? Is it housing, air quality, education, or is that?
So I don't have one. I think that there is, again, it depends on the framework you look at. So smoking, for example, is a major cause of poor health. So that's one particular area to tackle. There's a whole set of things around obesity, which is increasingly a very significant factor on our health. Obviously, obesity is a very complex set of issues, which is all to do with diet and access to food and access to reasonable choices, but also activity levels. So that's a whole set of things around active travel, around how people genuinely have access and choice to affordable food. And so that there's quite a lot of different policy levers that could help improve obesity, but that is a very significant cause of ill health. And linked to that is high blood pressure is also a very large cause of cost of healthcare and ill health. Quite often high blood pressure is caused by obesity. So you can start to see what are the main causes of poor health, and kind of step back from, is it high blood pressure, is it cancer, and see what are causing those, to then help you think through how can government intervene and use all the levers available to support improvements.
So, Sally, I'd like to come back to that. Even as you were talking, I see someone called Ushma Barros has made this point about loneliness and social connections and health, and I'd like to sort of explore that subject. But I'm going to come back to that, and clearly we haven't even touched on some of the big questions, social care, etc. I'll come to those in a moment. But I wanted to bring in Dr. Pearson Studdard. Johnny, thank you for joining us. There's a really interesting point that Sally makes, which is, you can come number one for healthcare systems out of 11, and then 10th out of 11 for health outcomes. And I suppose one of the things that's been arresting about this pandemic year is that we as a country in the UK have looked ourselves in the mirror and realized we're quite an unhealthy country, and that there are issues around our health that we probably didn't really appreciate. Can your book, Whose Health Is It Anyway, is a much more broader look, isn't it, around health than just at the NHS? Can you just spell out what the argument of it is?
Yes, thanks, James, and thanks for having me. And so many of this really sort of complements very much what Sally was just saying. And so the thesis of our book is that we always talk about illness being a drain, and that we hear about illness being a drain and the NHS taking infinite money from the public purse is the narrative we often hear in the media. But that actually what we're seeing is that the links between health, good health, economic outcomes and educational outcomes are increasingly interlinked. And actually the pandemic has clearly shown that in the negative aspects, and certainly with respect to inequality. So during the pandemic, those groups who are most likely, whether that's through deprivation or certain ethnic in terms of ethnicity, who are most likely to catch COVID, were also the most likely to die from it. More often than not, for example, the lowest 10% of earners were 7 times more likely to be out of a job during the first lockdown than the highest 10% of earners. And similarly, those children in those families of the lowest 10% earners were much more likely to have their learning disrupted during that. So we show that ill health impacts education, employment, and economic opportunities for individuals, but also as a nation as a whole. And when we look at why that is, a lot of this is because over the last 30, 40 years, we've done very well at keeping people alive. So death rates from things like heart attack, really common causes of death, heart attacks, strokes, have come down fantastically, more than 70%. But what we haven't been as good at is stopping people get the conditions in the first place. So there's prevention. So people are living longer with many more conditions, staying alive, but that impacts their ability to work, frankly, to enjoy life. And so one of the analyses we actually did at Imperial after the first wave looked at excess deaths, how that compared in England, Wales, Scotland, and 21 other countries. And we found, as we all know, we did really poorly. And we tried to tease out why that might be. And there are the policy responses, which many people have discussed about, locking down early, test and trace. But the other two areas were the health of the public when the pandemic hit. So clearly, as you say, our obesity rates are some of the highest in Europe, our multimorbidity rates, all of these things that we know, sadly, increase the risk of having a poor outcome from COVID. But then secondly, the resilience of the health, public health and social care system, many of the issues that Sally's mentioned and written about so widely. But for example, the public health system, where I work, we had to stop testing and tracing people in the community just as the pandemic started, because we've spent the last 9 years taking those resources away. And so it's that idea both of how resilient is our public's health, and that's because of the environment around us, as Sally mentioned, and have we invested in health rather than illness, but also how resilient is our health, social care and public health system. And again, that's because have we been valuing health how we'd like to.
And Johnny, let's just pick up on that last point about investment in health versus illness, and just take each in turn, because I don't want to just sort of glance by. I don't want to sort of take on Sally's argument and say, look, there are the wider determinants, we need to look at that. And then, if you like, give a free ride to those people who are saying, well, actually, you know what, there are real funding problems, acute funding shortages within the NHS, within our healthcare system, and we do need to address those because we do have an illness problem. So can we park the health issue for 1 second and just the funding of systems that address illness? What do you think needs to be done to help on that front?
Absolutely. So the way that we phrased it was in the sort of wider health ecosystem, you've got the environment and all of those determinants that Sally mentioned that lead to us being less likely to live well for longer, get disease and so forth. And then you've got the health and care system. And within the health and care system, it's fair to say that the NHS generally is an illness service and does that very, very well. So if you say that was perfect for when it was set up, and it's still very, very good if you're having a heart attack or if you've had a car crash or if you're intensely unwell with COVID. But actually, most of our health issues in this country day to day are chronic diseases. And so chronic diseases, generally, the idea is how do you control them so they're not a part of your life? And part of your life shouldn't be coming to hospital regularly. And one of the underlying problems with that is generally, again, we sort of pay for activity. So the way that systems are set up is if you go to the hospital gets paid for that. But actually, if you've got diabetes, the last thing you should be doing is going to hospital. You should have whatever the care is that's needed for you at home in the community as an easy part of your life as it is to keep every other part of your life in tip-top shape. Mm-hmm. And so our incentives around that system structure largely follow the illness rather than actually going the other way around and promoting health and keeping people within even the NHS system, keeping them healthier for longer.
Well, Johnny, thanks. I want to come back to that. I want to just bring in a few people because as you were talking, as Sally was talking, there've been a sort of a number of questions or points of view. I should say one of the rather loosely enforced rules of our thinking is we don't ask questions. Everyone gives their point of view because often we find that people ask questions, but they've really got a point and we really want to hear that point. I wanted to hear from Ushma Barros, who made this point about loneliness. And I wanted also to bring, if I could, DJ Hamlin-Brown, and I'm going to bring in Julia Gaskell too. So I'm going to bring in a few different points of view and I'm going to come back to you in a moment, Sally. Ushma first.
Hi, it's great to hear this kind of reframing that you're both providing. And I think picking up on one of the questions we had around, the challenge around ranking different determinants of health. And I think one of the things, particularly in the pandemic, that we've seen is people feeling a sense of loss of social connections. So, different studies will show different things. I think one stat that I've seen in the past, which I may be misremembering, but was showing that social connections have a stronger impact on our health than even smoking in terms of that link. And I was wondering what you've seen in terms of where we are right now, what we can be doing to bolster those social connections that can really lead us to better well-being during this period.
Ushma, thank you. Sam, I'm going to take a note of it, but I'm going to bring some others. I wanted to, DJ Hamlin Brown. Are you Dr. Hamlin Brown? Because I know there's a Dr. Hamlin Brown who's written a paper on this subject.
That is me, yes. And
okay. Well,
thank you so much for inviting me to contribute. And I was really fascinated to hear Sally and Jonathan's contributions. I think they make some really, really important points. I think my own personal view. I'm an A&E doctor by training, and I've done some physician leadership in the UK and also in China. And it occurs to me that the thing that is lacking in an NHS system that was set up 70 years ago or more is this sense of agency for patients. And I take Ushma's point that social connections is very important for determinants of health, but I also think a sense of agency is really important. And I really like the Singaporean model, which says that you give people money through the state, they contribute, or you encourage them to save in order to then spend money on government-provided healthcare services. One of the worries for the Singaporean system is that although there is a safety net, it's not very explicit. And if you become extremely unwell, then there is a chance that you can become impoverished by your disease, which obviously is what the NHS is there to try and avoid. I think the idea of having something which is a hybrid between the NHS total safety net and something which has a sense of health savings, so that patients can have agency in how they improve their health. To Jonathan's point, which is if you spend money on improving your health, then there's chances are that you'll have a longer, more high quality life. And so the paper that I've written really was just an exposition of that idea, that we could have a hybrid of an NHS safety net plus health savings account like Singapore.
And sorry,
that's my big idea.
I'm sorry. Will you just explain it for 1 minute? So the idea would be that I pay through general taxation for the system.
Yeah.
But how does a health savings account work?
So my suggestion would be that every man, woman, and child is given a certain amount of money, probably about £1,000 a year, which they put into a health savings account from birth. Then, as they get older and sicker, they have a pot of money in order to help them address health problems in their lives. So it'd be quite difficult to bootstrap such a system, but imagine you're 40 years of age, you're given a pot of money by the government of, let's say, £40,000, to which you can then contribute every year. And what happens is that then you use that for those aspects of health and wellness which you want to choose. So whether, for instance, you have a hip replacement or not. What it's not used for, in my view, is for the things where you don't want to choose. Like if you get hit by a car, as Jonathan said, if you have a heart attack or if you get trauma or hit by COVID, you don't want to use your health savings account for that. So a proportion of it's about £1,500 per man, woman and child to fund the NHS. If the government provided half of that and we had control over the spending of the other half, I sense that we would be able to target the sorts of healthcare interventions which would improve our health by letting the patients choose that.
Yeah.
And that would still maintain the safety net, which the NHS we're so proud of and so happy about having.
Dr. Hamlin Brown, thank you. Julia, I'm going to come to you in 1 minute, but I'm just going to ask Sally just to respond to that. What are the pros and cons of a system like that?
So as with any different funding model, there are a different set of pros and cons to the NHS. I think there's obviously an immediate kind of concern for me is about equity. So actually, me having £1,000, I live in an environment and a connected community, and I have the opportunity to probably get considerably more value from that £1,000 than many other people would, who might not have access to the same ability to have clean air, access to safe exercise and active travel, etc. So I think there is, given that we have very, very considerable health inequalities in this country, and they've been widening over the last decade, I really worry about models that could exacerbate those health inequalities. So I don't think that the advantages of that scheme are so great that we should jump there. I think it's just also worth us just reflecting on public opinion about the NHS is astonishingly supportive. It's kind of, it is the nation's religion. The levels of support for the founding principles of the NHS are unbelievably high, and they are unbelievably high in every single age category. It's not that this is something that you think in generations this will shift. So given that really strong public commitment to the NHS, unless there is a model which is dramatically better as a funding model, rather than I think what a lot of people have been talking about are things around the delivery model for the NHS, then I'm not sure why you would want to kind of take the public through changing to a different funding model, which they really are kind of at the moment, all public opinion would suggest that they would really not want to move away from the NHS. So I kind of come back to the OECD, do not believe that there is a single model that is consistently better than any other model on this. So you've really got to challenge why would you move away from it?
But Sally, sorry, there's something also about the public support and the adoration of the NHS that is the reason for questioning it too, because it's so much harder to have a debate about systems around the NHS, because if you go near it, it feels as though you're going to come this kind of sort of barrage of public suspicion, let alone criticism. When you look at somewhere like Canada, right, just they have a different model, don't they, where the bulk of the system is paid for by general taxation, but there's greater participation, and to Dr. Hamlin Brown's point, that there's arguably greater agency. Do you think that the experiments the UK's had in trying to encourage greater agency, greater individual participation in your own healthcare, has failed because the nature of the NHS system, or that we just didn't give it enough time?
I think it's probably a bit of both. So there have been at various points reforms aimed at, if you like, sharing decision making and kind of sharing responsibility between the NHS and individuals. We've had in social care personal budgets for a couple of decades now, which are about, in effect, giving people their allocated budget and allowing them to make choices. And in recent years, the NHS has been looking to use that model for people with long-term conditions as well. So there is some movement in that direction. But I think you're right, there's a real challenge about how quickly people can see improvements on that, and also how do you help people with that agency. So actually not everybody is the same kind of type of consumer. People will need different levels of support to understand the options available to them. They will have different options available in different communities to support them. So it requires quite a lot of support to individuals as well. So I think that is kind of one challenge. But then I think there is absolutely a one of the downsides of a general taxation model is that you tend to have a bit of a boom and bust model, because the politicians find it harder to consistently increase taxes. And what you therefore find is that there isn't really the long-term commitment to some of these shifts in how you deliver healthcare, because if you're then in a kind of bit of a dip of spending, as we've had for the last decade, you're ending up having to kind of really just focus on the core of what the NHS can offer, rather than investing the time and effort of clinical staff and healthcare professionals in supporting patients to engage with their health in a different way.
Okay, Sally, I said I'll come back to Julie Gaskell, and Alex Coley makes an interesting point about blue zones. So I wanted to see if we could hear from him. Julie, are you there?
Yes, can you hear me?
Yes, we can hear you well.
Great. So thank you for coming to the question that I raised. It was really, I mean, it kind of touched on the point that Jonathan raised around, what our NHS is really good at, which is dealing with illness rather than dealing with focusing on health. And then also what Sally talked about, how our NHS, the perception of the NHS as this kind of amazing, fully supported, magical entity that provides everything. And I was just wondering what people's thoughts were about the mismatch between, messaging about what it is people should expect from the NHS and is like realistically able to be provided, and how the funding does in fact fluctuate. And do people hail it as being this amazing thing because they don't understand what should be expected from it, given the level of funding and the sort of fluctuations in the funding, and just how that kind of plays out with health outcomes. And as you said, like when people try and kind of make any changes to the NHS, like it just seems that
you can't touch it.
The expectation, isn't really in line with reality.
So, Julia, before we come back to sort of discuss that point, I'm going to ask Alex Coley, who made a separate point, but I want to hear your thoughts too. Hello, Alex, how are you? Oh, we can't, hang on, you're muted. There we are, hello.
I'm good, thank you. Great to join this thinking. I'm fascinated by Blue Zones research. I like any kind of research that's kind of out there and looks at things that are unusual or are on the fringe. So Blue Zones, which I imagine many of the health practitioners might have heard of already, are areas where you have people who live very, very long lives, much longer than most people. You get people living to 100 as a common practice. Places like villages in Italy, parts of South America, some parts of Greece. And for some time, researchers tried to figure out what was the kind of alchemy, what was the magic cure? Was there something in the lettuce in Italy that people were eating? What was this thing that kept people living so long? And what they found out was that really multi-generational living, where people are living together and are in a community and are friends and are supporting each other, is the magic ingredient. So where you have a 97-year-old living with her 74-year-old niece, and then her sister's children, and they're all living together and staying together. And it often happens in communities where multi-generational living is quite normal and is something that's happened for thousands of years. And of course, the weather helps, and of course, diet helps, and of course, exercise helps. But the mental health part of it is enormous. The fact that people want to keep living is the key. So I just thought I'd throw that in there for you.
Alex, thank you. I'm going to ask, actually, I'd like both Sally and Johnny to think about that. And because Sally, I'm going to go to you first, just to pick up on Julia's point, if you might. And will you, in answering about the expectation of our healthcare system, also touch on a subject we haven't discussed at all, which is social care, right? And it seems that wherever you are on the political spectrum, you agree that funding system's not working. So what should we do about that?
Great, a really good question from Julia. I think this the point about expectation is going to be really, really important for the next 4 or 5 years, because actually coming out of the pandemic, the NHS is going to have an extraordinarily hard few years. Its staff are absolutely exhausted. It's got ballooning waiting lists, and every number on that waiting list is a person waiting for an operation and treatment, and they will be nervous and anxious, and their quality of life will be poorer because they're waiting. So it's going to be really difficult. So I think being honest about expectations is really clear. We have an NHS constitution, we have set waiting times, and those kind of standards do seem to kind of accord with what the public think is a reasonable expectation from the NHS. But we haven't met those standards for about 4 or 5 years, and we're certainly not going to meet them in the next 4 or 5 years, given the consequences of the pandemic. So I think having an honest conversation with the public about what does the recovery journey look like for the NHS, what is a reasonable pace where our staff can deal with that, is really important. Because I think where you might start to lose public confidence in the NHS is if there is a real mismatch between expectations and reality. So I think it's an interesting, important point from Julia. As you say, social care, which has been an issue I've been closely involved with for 20 or so years. I think I've got the record of the most number of white papers I've written as a civil servant that have never actually been implemented. So social care system is...
What number was that? Sorry, what number? I got the number as 12, but is that wrong? How many white and green papers have there been on social care altogether?
So I think there's been 13. It slightly depends how you define white and green paper, and but yeah, around about 13, of which I've been involved in around 8 of them, I think, in various guises. But the key dilemma with social care is that it is going to take huge political courage to have the right debate with the public about it, because we need to spend more money on social care. We do not spend enough, and the money we do spend is spent on a very, very targeted means tested system. So you need to be thinking, we need to spend more, and then how do we share that spending more money amongst us all fairly? So what's the right combination of people individually paying for themselves, risk pooling, at a population level or at generation level. So it's a really hard conversation, made much harder because most of the public think social care is free. They think it's provided by the NHS. So you're actually, even when you're presenting a proposal which is better than the current model, most of the public think it's worse because they're comparing it to a free model. So it requires a lot of kind of steady explaining the current system, explaining the problems with it, taking people through the different pros and cons of different ways of funding, different ways of risk pooling to then reach a political consensus. What we've tended to find with social care is it's an issue that that quite often it comes to attention later in a government's tenure, so they don't really have the time to deal with it, or they deal with it first of all, thinking it's going to be quite easy and get their fingers burnt, and then don't come back to it. So Tony Blair and the Royal Commission, that was, he thought he would be able to grapple with it early on, and then actually that didn't work. Theresa May and dementia tax is obviously the more recent example of that. So it's really that kind of, how do you take the public on a journey where they understand the current model and then understand why we should be spending more collectively and individually.
Sorry, will you just so we understand, just in terms of scale and systems, what is the scale of the funding need for social care by comparison with the NHS? And you gave your options on general taxation, private health, social healthcare models. Is there an obvious one for social care?
So in terms of scale, obviously the numbers on expenditure is a bit funny in the last year because COVID's hit it all, but the NHS is around 120, 130 billion a year. Social care, both the means tested system, the government provider system, and the private market is around about 50 billion. We've got much less data about the privately paid for part of the market than the government provided. So it is much smaller, but in terms of employment, for example, social care employs 1.5 million people. That's more than the NHS employs. So it's a big sector, but it's a very different sector to the NHS. It has 20,000 different providers, the most of whom are private businesses or charitable businesses. So it's a very different system. In terms of
sorry, Sally, just one other thing. Social care inflation versus NHS inflation?
Social care inflation runs higher than normal inflation, but it's slightly less than the NHS inflation because it doesn't have some of the costs of, say, for example, drugs. So social care is predominantly a people business. It's about people supporting individuals in care homes, people supporting individuals in their own homes. There are some potential for technology interventions, but as I say, it's slightly above normal inflation, but a bit below NHS type inflation or healthcare inflation. In terms of the different models, again, despite the fact we've been debating this for 20 odd years, there's not a huge amount of models to pick from. There is a general taxation, free at the point of use model. There's a, which is like the NHS. There's a model of which we have now, which is basically you pay your own way, but there's a safety net. And if you're going to have that model, you need to encourage people to save more appropriately. And then you have a kind of a set of options in the middle, which is more about how do you share between the government and the individual. So how do you do risk pooling in a particular way? The most recent example and proposal on that was Andrew Dilnot's proposal from his commission in 2011 around a cap. And what that was saying is it's reasonable for everybody to, particularly when it comes to care in older age, it's reasonable for everybody to kind of plan and prepare for a certain amount of care because we can all expect to need some support in our older lives, but it's not reasonable for us all to have to plan and prepare for the absolute worst case scenario. So what this is saying is that you need to pay for the first certain amount of your care, but then once you've kind of, if you like, got beyond the average, the government will then provide care for free. So it was that kind of sharing. There's been other options provided by OneList, which is more about for every pound you spend, the government spends a pound, so a more direct sharing kind of as you go through your care journey, whereas Andrew Dilnot's was you do the first part of your care journey, you pay for, and then the government steps in. But it's all really about how you have the right level of sharing between government and state.
All right, Sally, that's massively helpful. Thank you. Johnny, can I come back to you on Alex Coley's magic lettuce? Assuming that they don't have the magic, or we don't have the magic lettuce, Lucy Huberman in the chat made this point about the defunding of public health. And I suppose Alex's point about blue zones is really a big public health question. What is the funding requirement there and the the policy requirements there that you begin to see those communities and those changes in behaviour?
Yes, well, it's a really good point on the blue zones, but also, I mean, generally, we study lots around the Mediterranean diet and so forth. And what we see is there are 5 modifiable risk factors that account for way more than 50% of all ill health and mortality: poor diet, smoking, alcohol, physical inactivity, and air pollution. Now, poor diet.
So again, poor diet, smoking.
I've got to remember them now: alcohol, physical inactivity, and air pollution.
Right.
And poor diet, the ratio. So smoking was the big issue in the mid 20th century and the late 20th century, and that smoking prevalence now has declined to around 15% in England, for example. Big inequalities. 28% of women smoke in pregnancy in Blackpool compared to 1% in Woking. So still big problems to solve, but at the aggregate level much less. Whereas the proportion of our health issues attributable to poor diet has been the reverse. That's got worse over the past 30, 40 years and led to big issues like obesity and diabetes. But there was lots of where most of the nutritional epidemiology is on chronic diseases focuses around cardiovascular disease and diabetes. We've been studying them longer. And as Alex was saying, we see a lot of that in the likes of the Mediterranean diet, where they're richer in the healthier fats. They're very light on unhealthy carbs and refined starchy carbs, and light in added sugar. Now, onto then, what do you do about it? So clearly, public health generally has been disinvested over the last 9 years. But that even if we were just to invest more into public health, local directors of public health and give them more resources, that would not fix the problem, because they would be battling against the tide of an unhealthy environment, makes everyone unhealthy. They've got to try and stop them from getting too unhealthy. You have to go back to the source. And so, in a nutshell, when we walk around our streets in the world we live in, it's much easier to make the unhealthy choice, whether that's because at the supermarket, with very time poor individuals, the quickest, easiest, most accessible, and often cheapest food is the unhealthy food. It's also, if we look at things like fast food, the density of fast food outlets, much more dense in the areas of more deprivation, who have higher issues with obesity and so forth. So there's no quick answer, but that things like the sugar levy or the soft drinks industry levy really have shown, it's possible. So the soft drink industry levy, before it even came in, 50% of all soft drinks in England had reduced the amount of sugar that they have in them. What's happened since then is sugar levels in those drinks have come down and industry revenues have actually gone up. So nobody's complaining. And I think that's a really, really big symbolic move, that we've been able to change something so structural, but actually with industry, because they've been innovative when the framework's been set there. So really taking these types of innovative approaches that set what is the framework, an industry like a framework, because then they know they're the rules, will innovate to make our models work around them. But set that framework so you're putting that health first, fewer sugar, fewer calories and so forth, and build from there.
John, it's so interesting, because I remember the fights over those taxes, the sort of sugary drinks, and how fiercely it was fought. And I hadn't heard that fact, that actually revenues from those drinks had gone up. It's really, really interesting. There are a number of people I've asked to come in just in light of points in the chat. Claire Bradbury, can I ask you, just because you'd made a point about gyms, and I've come to Sally Young and Dr. Fran. Claire, are you there? Can we hear from you? Yeah.
I am. Yes. Thank you. Thanks so much, James. The point I made was just about limiting the conversation to gyms, and I think we need to talk about movement much more widely. For context, I'm writing a book at the moment on livability of cities, very much anchored in the experience of the city dweller, and obviously movement and flow and active design comes into that a lot. But I think this is part of the narrative of co-benefit. So when we're addressing linkages between sustainable, inclusive, equitable places and healthy places as well. And I think the more we make fitness about gyms, the more inaccessible it becomes. And I say this as I'm also a fitness professional as well, with another hat on. So I think gyms are part of the mix. They're not everything. We've got tremendous value to tap into when it comes to outdoor places, and really mainstreaming having high quality natural environments as part of our day-to-day infrastructure.
Yeah, Claire, thank you. I mean, you would have enjoyed actually the conversation that Sally and I were having just before we got onto this call was about how do you translate health into the transport department. So I'm going to come back to that in a moment, but I'm going to just bring Sally Young too. Sally, can we hear from you?
Good morning, everybody. My point's more about the culture of the NHS, because it has an incredibly internal culture. It's not good at partnerships, no matter what it says, whether it's local authorities or with patients or carers or voluntary organisations. And if we are going to change funding, where does that put accountability? Because at the moment, decisions are incredibly remote, and there are currently discussions taking place, as many of you know, about having larger, what are called ICS, the alphabetic soup areas, very large, very remote decision-making boards. So what about accountability if funding models are going to change?
Sally, thank you. It's a really good point. Fran, well, I'm calling you Dr. Fran because your name is Fran and you say you're a GP. I don't know whether we can see you, but maybe we can hear from you.
I can't get my camera working. Sorry. Yes, I'm Fran. I'm Dr. Palmer. So I'm a GP, and so I'm there at the coalface in the NHS, and we were in crisis before COVID, really, and lots of really interesting comments coming through on the chat. Having been someone who works within the NHS and also as a GP, we see ourselves as the gatekeepers to the NHS in terms of secondary care, the hospitals. I think it's very complex, and also the population are not heterogeneous. You know, you have, and I also think personal agency is a really important factor. As a GP who is trained in medicine, I see myself as somebody who is there to look after sick people, and I share Dr. Hammond's thoughts about that kind of personal responsibility of funding. I have lots of patients who are very sick and are not getting the care they need. And I also, less so now because of COVID and they changed to consulting, but we've had lots of patients who we feel are wasting our time and using the system inappropriately. And it's about trying to make sure to signpost, and what we've been trying to do is signpost people to other healthcare services, helping them to access healthcare from places other than the NHS, like your pharmacy, like education. We also have a really fantastic a pilot scheme in Exeter in Devon, which is called Wellbeing Exeter, where all of the allied sort of charities and for exercise, for mental health, for loneliness, have come together and have support workers. So if I have a patient who's coming to me with something which I don't think is medical but illness, I can direct them to this organisation who provide that element of healthcare, which ties in with exercise. So I can focus on looking after people who are what I would say are sick or are ill. I also,
I'm just going to interrupt you because the sound is not brilliant. But I definitely think we got the point about personal responsibility and the capacity to direct people to other organisations and agencies that might help. And just as ever, I've run over on time, so I'm going to ask Johnny and Sally just to respond to those points. Johnny, would you go first, just with a final thought, particularly about this combination of Fran's point and Sally's point, which is about, personal responsibility, organisation. The NHS are working with other organisations and the implications for accountability. When it comes to Sally, if I might, Johnny.
Yes, thanks very much. And Sally, as you say, one of the important things I think, and what we miss too often is actually the joined upness of it, of having those who are actually very much on the front line, but also seeing this huge, really more and more morbidity, the multi-morbidity lands on the doorstep of primary care, and yet no more both resources, but also that sort of diversification of skill set and or bringing out some specialties from secondary care to support that. So on the personal responsibility one, I think it's really, really interesting, and it's a very topical debate both during COVID and how we go about with the restrictions, but also it's always there with obesity and certain there is a view that personal responsibility should be taken more, then there is a view that that's not the case. And my own view is that I think individual responsibility is all very well if there's that equal opportunity to make either the healthy choice or the unhealthy choice. But for all of the reasons that we've sort of outlined, it's just not equal. You know, I mentioned that, you know, the women in Blackpool who smoke in pregnancy is 28% versus Wokingham 1%. Now, there is not an equal opportunity for all of the extremely complex factors that go into that, what's happening there. That does not make that opportunity equal. So I think personal and individual responsibility is a very worthy concept when those opportunities are equal. Yeah. And conscious of time, James, so I don't know if you want me to go on to the second for Sally to.
I'm going to join. I'm going to interrupt if I might, just because I got strict instructions to end at 9:45, so you can see how well that's going. Sally, would you just pick up on the point? Actually, personal responsibility and the thing that Fran touched on, which was, you know, time wasting, which must be incredibly frustrating if you're an overstretched doctor in the NHS. But we also deal with Sally's point about accountability. One of the things we haven't talked about is the very variable outcomes within the NHS, between hospitals, and accountability on that front. And then you've worked in government. I'm really intrigued to Claire's point about a kind of broader understanding of health and mobility. You know, does Grant Shapps as Transport Secretary wake up each morning and think, what can I do for the nation's health? You know, you've got to ask yourself that question. So will you just touch on all three of those?
Yeah, of course, in 90 seconds. So here we go. So I think, and this kind of goes back to Jonathan's point about actually the sort of equality of opportunity to take personal responsibility. I think we really need to get below what's causing what might look to some people like inappropriate use of healthcare services, because actually it may well be that they're going to their GP because they can't access other care in a way that fits into their life and the other issues they're dealing with. It might be that they're going to A&E because they can't get a GP appointment in a way that works with their work, because the gig economy might mean that they're not able to take time off. So I think there's quite a lot that drives how do people use the NHS. I do think within that is actually, do people understand the cost of the NHS when they're using it or not? But I think there is quite a lot that sits underneath this that I do worry that policies that are trying to tackle inappropriate use of the NHS are likely to increase inequalities, because it's very hard to do that in a way that doesn't also deter appropriate use from people who might find it quite hard to access the NHS. So I think it is something to look at, but as I say, there's worries there. Accountability is an interesting one, but again, I think I'd come back to accountability for health and care services versus accountability for health. So health and care services, I absolutely agree with a number of the points people have made about the culture in the NHS, how good a partner it is or isn't. They are currently going through a set of reforms where I'd say in my 20 years, this is, they are talking the talk about partnership and talking the talk about population health and overall health outcomes in a way I haven't seen in 20 years. But in most cases, it's still talking the talk. And we need to start to see that shifting. But it is important that there's a connection to, after all, we're spending 120, 130 billion pounds of taxpayers' money, so accountability does need to be clear. But then the final point about Grant Shapps. So actually, I think Grant Shapps personally does kind of get to this point around active travel. So the Department for Transport has been quite good on things like cycling, active travel, walking. Some of that's around health, some of it's around net zero. But you can't just have it the whim of an individual Secretary of State. What you really need is a proper structure and system that means that all parts of government are thinking about the impact on health. So having a health index where we're clear about measuring our health is really important. But you can also have policies like having a health in all policy approach, or having a health impact assessment for every single policy. Other countries in the world like New Zealand have that model, which allows you to understand, if I do X, which I'm doing for my the DWP set of organisational objectives, what impact might that have on health? So you can start to put a framework around it, which makes it more systematic rather than based on the sort of personal preference and interest of individual cabinet ministers.
All right. Well, Sally, thank you very much, and Johnny too. It feels as though we've just started, but even in the course of this busy hour, I feel I have a much clearer sense, I suppose, really about three things. One is just the extent to which we need to think about health and wider determinants rather than obsessing necessarily about the NHS. And the more we can dig into and understand how precisely those things impact health outcomes, the more likely we're not going to see a country which is realizing in the light of this pandemic the issues of comorbidities and multimorbidities. The second one is obviously there is a big structural ask in front of us around social care, and this issue goes unaddressed. But I think there is something that you hear in the conversation which is around personal agency in a system that is understandably run through general taxation, and it comes out in the points that Dr. Hamlin Brown made, but Sally Young too, and it sits between choice and accountability. And so I hope that, you know, in the coming months, we think more deeply about this, we'll explore those points. Thank you to you, Sally Warren, to you, Johnny Pearson-Stullard. It's really, I can't tell you how invaluable it is to be able to stop and think about our systems and the way in which we manage health, particularly a time like this when we're so obsessed and it feels so close up in our faces. So it's been really helpful. Thank you to my colleague Luke Bedimer, who put together the slides at the beginning of the session. All of those slides and all of the notes are up on the Tortoise website, so do take a look. We're going to go from this to my colleague, fellow editor, Kerry Thomas, who's going to be addressing one of the most stubborn and pervasive problems, namely Alzheimer's. Can we find a cure for Alzheimer's? It starts in about 3 minutes' time. Kerry, I'm going to hand over to you, but for now, thank you very much to Sally and Johnny. Thanks, Claire.